Session. As you can tell, we are not Elton John. That's in a different room. It's a privilege to co-moderate the session with someone greatly respected in the HIV community. Sean Mellors is South African. He's been living with HIV for 26 years. He's a board member of the Communities Delegation to the Global Fund, vice chair of the Strategy Investment Impact Committee, and works on HIV treatment programs in South Africa. Just to set the scene for this session, as we all know and have talked about for the last several days, there's been a massive scale-up of prevention care and treatment in the last 10 years, in particular in sub-Saharan Africa, and we're privileged to have two of the leaders from Rwanda and South Africa who have been behind those increases. And we're looking forward to ending the epidemic, and we're going to talk about that in a little bit. But this session is focused more on how we ensure maximum public health impact and what's needed to achieve this, how best to access and efficiently utilize the resources from different streams and have an optimal return on investment. How do we do as much as possible to align the country needs, which are prime and the most important things, with global engagement? And how do we ensure engagement of civil society, including people living with HIV? And we have a spectrum of epidemics represented here. We have East Africa, South Africa, and Eastern Europe. And so we'll have an excellent conversation, we think. We have an extraordinary panel to discuss this. His Excellency Motlanthe, Deputy President of South Africa, who has led an extraordinary increase in the response there with remarkable results over the last several years. Her Excellency, Agnes Mwahu, the Minister of Health of Rwanda, who's been involved with the fight in HIV/AIDS. I got to meet my sister when she was the head of the National AIDS Council there and is progressively, so she's been leading the AIDS response for many years now. She's just formally overseeing the whole thing as Minister of Health. His Excellency, Ambassador Eric Gooseby, the director of the PEPFAR program, Dr. Andrei Klepikov, who is leading an effort in a very difficult part of the world in the Ukraine. He leads the International AIDS Alliance there, and Dr. John Blanford from the U.S. Centers for Disease Control and Prevention. Minor housekeeping, as you can tell from the setup here, we do not have prepared speeches. We will have no singing, since Elton John is in the other session, unless Your Excellency would like to sing a few bars for us. We intend this to be an interactive session, and what we're going to do is follow some themes. There'll be three themes that we're going to be discussing, some of which overlap, but we're going to try to concentrate on them and have an interactive discussion around them. The themes are process, strategy, and internal financing, and that will be the first theme we discuss. Implementation, challenges and opportunities. And thirdly, alignment of country planning and strategies with external partners, which would be the two gentlemen over here to the left. So with that, I'll turn it over to Sean to introduce the first theme and begin the questioning.
Great. Thank you very much, Mark, and good afternoon, ladies and gentlemen. As Mark referred, to ensure that we have an effective HIV response, it does require commitment from a variety of sectors, including government, private sector, civil society, people living with HIV. Mr. Deputy President, under your government and with your personal leadership, South Africa has made remarkable progress in the struggle against HIV. The South African government now provides 90% of resources to fight HIV. And as Deputy President and Head of SANAC, you have all the levels of government involved. Why is HIV a priority for you and your government? And what do you think are some of the lessons learned from South Africa's experience that you can share with us in terms of achieving an AIDS-free generation?
Well, thank you very much, Sean. AIDS is very important to us as South African government because we started off Is it fine?
Yes, now it's
Okay. Yeah. Now, thank you very much, Sean, for the question. AIDS is very important to us as South African government because we started off on a rather shaky footing. In the first phase, we were overwhelmed by the outbreak of this pandemic, and our responses were not well coordinated because as government we were pulling in one direction, whereas civil society, led particularly by activists, those living with HIV, were pulling in a different direction. We've now reached a point where through the South African National AIDS Council have the same approach. We have government and about 19 different sectors of the South African society participating in SANEC. And it is this body, SANEC, which led, of course, by people living with HIV who are organized in two formations, NAPWA and TAC. And so the national strategic plan was developed with the all-inclusive participation of all these sectors. They involve business people, those in the entertainment world, sports people, community-based formations, traditional leaders. We have, for instance, in one of the provinces in KwaZulu-Natal, it's a community that has not been practicing male circumcision for over 200 years. But once it was proved that medical male circumcision reduces the chances of infection by about 60%, the king of the Zulu people became the champion of persuading male folk to practice medical male circumcision. So, in a sense, the response has been very positive, and we believe we've come to this AIDS 2012 with the understanding that we are about to turn the tide, and you know, through full participation, we are at a point where there's no longer any stigma. There's general acceptance that with a comprehensive response, we can create an AIDS-free society. Yeah. Thank you.
Thank you very much. Thank you very much. Come, guys. Thank you. Thank you very much, Mr. Deputy President. Minister, if I could turn to you now. Part of what His Excellency was saying or referring to is what is needed to turn the tide. Could you share with us a little bit as to what are the drivers of the epidemic in Rwanda? And what is the success story for Rwanda in combating infections?
Thank you. Your Excellencies and dear public, I think it's first of all an honor to be here.
Thank you.
And to talk about what we have done in Rwanda. So the driver of the epidemic, I think Rwanda has faced what all African countries have faced in the year 18. But during the genocide, 1994, there was massive rape to kill survivors, the women, slowly with HIV/AIDS. So this was one of the drivers. The other drivers, we have done modeling, actually. We have done modeling, and we know where the drivers are, and we have special programs to change behavior. We had the chance to have a high commitment at highest level. You know, His Excellency in the year 2000, when I was the Executive Secretary of the National AIDS Control Commission, put his personal weight in that fight. Her Excellency the First Lady also. And for example, it was asked to all leaders when they were out for any speeches to talk about HIV. Meaning you had the minister in charge of environment planting a tree and say, if you want your children to see those trees grow, protect them against HIV/AIDS. Everything was an opportunity to mainstream the fight. So it has changed behavior, and that's how we have stabilized the epidemic over time. Over the last 10 years, 2005 DHS, it's 3%, and now it's still 3%. Knowing that we have a rate of adherence that is 90% and a very little rate of death, meaning we start really to control and make it a chronic disease management. How we have get there? It is because HIV is not taken as an isolated issue. It's a health issue. And health is just a piece of our development. HIV is a piece of health. So everything come and flow easily. And led by the national vision, what is our Vision 2020. And this vision has been designed with the civil society, the leaders, the parliamentarians, the religious, everybody. And together we have designed the national plan for the country. And in that we have health, and in that we have HIV. So that means everybody is working for the same orientation, and it flows. We have a legal framework. The other thing why it's a success is because everything is based on equity, as stated in the Constitution. Geographic equity, gender equity, age equity. Meaning we have to assure that everybody is on board, and when we, on our journey to universal access, there is nobody left out for any reason.
Thanks to both of you. And before I deal a little bit with prevention, I just wanted to follow up a little bit to some of the comments you made, because I think they're really important. We have a deputy president, so you oversee all of cabinet. You have access to the finance ministers, and you can make sure things are integrated. And we heard the minister talk about the important leadership of the president, because it wasn't just health, it involved all of them. I'm wondering if you could, because that's not unique, that's somewhat unique, it doesn't happen anywhere. I'm wondering if you've already alluded to it, but if you could say a little bit about how it is that you ensure, or what advice, lessons learned do you have for how you engage across government so that it's not just in health, but that it's seen as part of the finance minister's response and part of the education response and part of something broader, because as long as we're just in health, we're going to get stuck. And both of you in your countries have been able to do that. I wonder if you could share some lessons learned on what arguments needed to be made to allow that to happen.
Excellency.
Well, in the case of South Africa, as I said, within the South African National AIDS Council, where there's a number of government ministries that participate in it: education, basic education, social development, finance, sport and recreation, women, children, and people living with disabilities, environment and water affairs. So it's a whole range, labor, it's a whole range of ministries that participate within the SANEC structure. And of course we've got an interministerial committee as well within cabinet to coordinate the response and to ensure that we mainstream the response. Of course, the lead ministry is the Ministry of Health, but it's with the support of the rest of cabinet. And so the important lesson is that because we've had 2 phases in our response. The first phase was characterized, broadly speaking, by government, as I said, going one direction and civil society in the opposite direction. And now we have united all the sectors behind a single program. It's a long-term program. The National Strategic Plan now covers the period from 2012 to 2016. And of course, it forms part of a long-term view with regards to the national plan as well of the country, which is a 30-year plan. And we deal with the social determinants because within SANEC, there are people who bring lived experience and all the challenges of whether people who are on treatment can take their treatment on empty stomachs. And so all of these issues are dealt with simultaneously. We've had one of the most successful HCT campaigns where, people were being tested, not only for HIV, but for all other diseases, high blood pressure, sugar diabetes, and so on. And so many people came forward. We tested. Our target was to test 15 million. We've covered 20 million. The response has been overwhelming, really. The response has been very, very positive. And the one lesson that I think is important out of all this experience is how once there is a unity of purpose, where it is possible, and a clear program with clear steps, it is possible to mobilize the broadest cross-section of the population in this effort. Thank you.
Thank you, sir.
I think Your Excellency designed what it takes. Consensus, participation, bringing all the constituency together around the subject, and ask to each and every one, what is your priority? Put all those priorities together and do the priority of priority, and then draw a plan. But and when you ask each constituency to do that, to contribute to it, it's easy to implement because from the starting they are there, they design with you, and we have what we call our economic and development poverty reduction strategy. And we have 12 sections: justice, government, education, etc. As the country decides that it's a cross-cutting issue, all sectors have to have a plan for each other. You have the Minister of Justice, the environment, we talk about those condoms, but who think about the recycle of those condoms? This is plastic, So all those things we think about that, and each sector come with its own sectorial plan, and with that sectorial plan we do the national plan, and everybody follow. This is the key of the success.
Thank you. Excellent lessons from 2 countries that have succeeded, and the need that aid can't be off to its side, but has to be part of a national response from the president on down and the leadership of the deputy president. We're going to take a slightly different tack now. I'm going to ask Eric and John about this, but I welcome responses. And then we're going to go to Eastern Europe after we leave Africa for a little bit. One of the things we're talking about at this meeting, and President Obama and Secretary Clinton and you, Eric, have called for the AIDS-free generation, and we do now have technologies that would at least allow us to effectively end the epidemic, which means getting to a low endemic stage, but that takes a lot of planning and strategy for how you do that. And we can talk a little bit about that in general, and then we'll ask for some input. But one of the striking things, if we want to be data-driven, from the data that I've seen over the last 3 or 4 years, starting with Namibia, then South Africa, now Botswana, are rather striking data that young people, variable by country, 21 to 24, we see 50, 60% reductions in incidence measured off prevalence, but still, it's probably incidence when you're young, right? but no change at all above that. So these 25% reductions are actually a balance of 50, 60% reductions in the young and nothing in the older. What are we doing to understand that, and can we begin to put together a strategy to end the epidemic unless we have a better grasp on some of these data that are coming out? And is that replicable, say, to East Africa? So are you all working on that at all? And do you think we need to focus on some of these issues if we're really going to understand how to put together a strategy to end the epidemic?
Well, thanks, Mark. That's a tough question. You've highlighted a real dilemma. You know, these epidemics are not one epidemic. They're multiple epidemics. If you are a leadership trying to mount a response to it, you have to think of it as separate epidemics by your demographics of your epidemic, in terms of your risk groups that are participating in behaviors that increase their chances of seroconverting. And you need to geomap kind of where those populations or individuals are relative to your medical delivery system, both in the prevention and the treatment component, but mostly the prevention. Once you do map it, you then try to position your prevention interventions so they are in front of that progression through that population. It's a lot easier said than done. The specifics of that mapping change quickly. The events that impact where people live and where they go, how easily they can go there, are they resourced to go there, you know, men, money, and movement kind of ideas that we used to throw out a long time ago, are really still very operant, and we need to have the sophistication in our information systems to be able to discern those relatively subtle differences, and then have an implementation system that allows for that kind of flexibility to stop one and move to another, or to reconfigure those that are already positioned but not interfaced well with the population and not in front of the epidemic. I think that is really difficult to do, and it requires a sustained political will. It requires a sustained information system that continues to inform, and it requires that communities that are participating in high-risk behaviors that are not legal or are perceived by the society as unacceptable, that they have created in that medical response in the prevention arena safe space so they can convene and dialogue with medical delivery systems and prevention efforts to better align the intervention in front of that expanding movement of virus. John can speak to it with a little bit more, I think, science around how to do that. But over the years, we have failed miserably at keeping in front of epidemics. I'd include TB in that. We know what to do, but we can't sustain the will and then the repositioning of all those logistical adjustments.
Do you want anything, John, before we ask our...
No, I think the ambassador summed it up nicely.
Your Excellency, Mr. Deputy President, Minister, would you like to reflect on that at all, or we can move to Eastern Europe and give you a pass?
No, that's fine. Let's move to Eastern Europe.
I want to say that it's not surprising that the change comes through the youth. The youth are more flexible than people of... okay, I believe I'm very flexible, but the youth are more flexible. If you want to change the world, use the youth. Don't use the people over 40, even if there's still a lot to propose. But I'm not surprised at all, especially when we talk about sex.
But if we talk about treatment as prevention, I would bet your average age of treatment isn't 22. It's probably closer to 26, 27. Yet we're still seeing all the change in the lower age group, not the older age group. And as we move into these new modalities, I think you're absolutely right. It's just, as Ambassador Gooseby said, trying to track these is going to be extremely difficult. And we know flexible because you change over time. It's going to be hyper flexible as we start to understand the data.
To add one thing on this, there is this intersection between health and wealth that we do know about. And I think one of the things that we have seen profoundly in recent years has been sort of the tremendous growth in sub-Saharan Africa of the economies. And I don't have an answer here, but I would be curious as we investigate going further where economic opportunities for careers, educations actually lead to lower risk behaviors, and whether that's being reflected in some of the recent data.
Well, maybe you guys can investigate it because I asked you to 4 years ago.
Great, thank you very much. Andre, if we could come across to Eastern Europe now, because I think unlike Africa, where HIV infections are flatlining or on the decline, it's the complete opposite in Eastern Europe and driven by intravenous drug use. From a planning perspective, what are some of the challenges in trying to address such an epidemic? And what are your thoughts around some of the recent data of the epidemic moving into the general population?
Yeah, thank you for inviting me being part of this panel. Actually, situation in Ukraine is a bit dissonating with the overall mood of the conference. We don't feel end of AIDS. We don't feel that we are approaching AIDS-free generation. Unfortunately, in our region, AIDS mortality is still growing. Most of the vulnerable to HIV infection groups are still neglected by the countries and by the government in particular. So that's why really my attitude, my feeling is rather concerning than optimistic. And nevertheless, it's quite important to think what can we do in order to catch up. And what we know from our experience that focused prevention, combination prevention is working very well in Ukraine. Over 7 years, we actually managed to stop epidemic in population of injecting drug use, which used to be a driving force of the epidemic for 20 years. So now incidence in this group is getting declined. And in neighboring Russia, it's going up. It's going up because there is no harm reduction there, because there is no opioid substitution therapy there. So that's why for our region, focused prevention is not only a theoretical model, but actually proven concept for boosting further HIV/AIDS response. New concept, treatment as prevention, is very encouraging and very relevant to our region because access to treatment is still very, very limited. Why? Again, because of active drug users are easily getting neglected by doctors. If we look on proportion of IDUs among HIV-positive people, it's more than 50%. If we look on the percentage of active IDUs on ART treatment, it's not 50%, it's not 40%, it's only 8%. So that's why our target is actually more difficult than in many other countries. Another thing, that treatment actually for IDUs is more expensive because you have to treat not only HIV but also TB, not only HIV but also hepatitis C, not only HIV but also provide substitution therapy. Costs are more expensive, so that's why it's really challenging context, and we need to apply more efforts in order to achieve this overall global target.
So in practical terms, Andre, what does that mean from a planning perspective? What has to happen on the country level to address some of those challenges which you've just identified?
From one side, it's elevating political leadership in caring about this program, because epidemic is still driven by the vulnerable groups, and for some high-level politicians, they not to be associated with drug users, with sex workers, with men having sex with men. So they are closing eyes on this problem. So this is issue number one. Secondly, at the stage of the national planning, it really looks like a balanced response. We have funding allocation in the national program for not only for RT and procurement of test kits, but also for substitution therapy, for focused prevention, for STI treatment. But when it comes to actual budget allocation, it comes to zero. It's very important to understand, because it might be different from many other countries, that from governmental funding, we have zero funding for focused prevention from state budget, zero funding for STI treatment, zero funding for substitution therapy treatment. And this is terrible, and this is not unique only for Ukrainian context, the same in other countries. So that's why donors funding from PEPFAR and Global Fund is really decisive funding for the next 3-5 years to turn the epidemic.
Thank you, Andre. And actually that leads well into what we're going to want to talk about next, which is theme 2 on implementation. Because we can put great strategies into place. And of course, political will and money are one part, but we wanted to focus a little bit more on the nuts and bolts of having a great strategy, including one to end the epidemic or becoming a low-level endemic infection, or ultimately ending AIDS. It's another to implement it. In fact, even under the administration prior to yours, Mr. Deputy President, there was a fairly good plan in South Africa. Ambassador Gooseby helped write it. It just never got implemented. But now both of your countries have put together extraordinary plans, but more than that, you've actually implemented them. And aside from the political issues and the financing issues and the structural issues, what are some of the major implementation challenges to actually go from that vision to getting the country around to the supply systems, the human resource systems, to making it work? Mr. Deputy President, I know that could be a little bit lower down than you usually deal with, but maybe some high-level thoughts on what you need to do as the chair of SANIC to focus people on delivering. And then maybe, Minister, you could follow up as well with some of the specifics that you have to work on a day-to-day basis.
Well, from our side, you know, the members of SANIC, the sectoral formations, not all of them have national presence. Some are regionally based, others are provincial, and some are national, have national presence. And so we initiated a process of ensuring that the structures cascade down and that each of these organizations can do the best with limited resources at the coal front where they are involved in. And so from government side, at national level, we have the Interministerial Committee, the Ministry of Health leading, and we have in each province, we have 9 provinces in South Africa, and each province is led by a premier. So all the premiers chair the provincial AIDS councils, and that cascades down to district level, up to local level. That's to ensure that, firstly, none of these formations lose out on support and funding, and secondly, to ensure that they continue to do the good work that they are involved in. Because if the structure is only efficient and well-oiled at national level, these formations can very easily fall through the cracks and we made sure that none would lose out of the new effort. We've also, as government, allocated more resources, whereas the overall budget for health has not increased over the past 3 years. We've, however, taken a decision that the allocation towards the fight against AIDS would be increased by 15% over the next 3 years. Of course, there are gaps, and that is why we continue to value the support of PEPFAR and Global Fund and so on, all of our international partners. But in the main, we have tried to ensure that government also plays its part. And we mobilize local business sector by sector. The mining sector in South Africa, for instance, has many workers who live in single-sex accommodation, thousands and thousands of them. And so we also interact with the Chamber of Mines with the view of integrating the program. So the overall plan also covers them as a sector. That goes for other sectors, the trucking sector and so on. Yeah.
Thank you.
Thank you.
Minister?
So I think that it's the same principle, you know, and it's those principles that we apply not only to fight HIV/AIDS, those are principles of governance. And the key word is accountability, meaning all along the chain, as each and everyone has a duty to the fight against HIV/AIDS, as well as other health issues or social issues, education issues, we have a contract. Personally, I sign a contract with Excellency every year on key indicators across the health sector. HIV is in. The mayor, all the mayor, we have 30 districts, sign a contract with His Excellency also, but they have also HIV indicators, etc. We go up to the village, meaning each and every one is response to those indicators. And if I fail, I may have reason to fail. Maybe there was a catastrophe or I was sick, I don't know. And I have to explain why. So this makes things happen. And His Excellency, there is a minister in charge of the President's office who follow all this with His Excellency. And in the end of the year, we have to respond to that, and we are evaluated by an independent body. And it's not a joke. Eh? It takes a day. We sit there with all the things we have to achieve, all the report, all the proof of actions. A report is not enough. But also, they go and see if what I say, what are the benefits for the population. It's not only that we have to do good. People have to know what you have done for them. Meaning, if you don't do, they can complain about your lack of efficiency. So accountability, and also it's easy because when you integrate at all levels, HIV is not just an infectious chronic disease now. It's integrated across the health centers. So when you do that, you have more the support of each and every one. I cannot succeed if the minister in charge of local government doesn't do his job, if the mayor doesn't do his job, etc. So we are all supporting each other, but we are all watching that each and every one is doing his job.
So far from both the strategic and implementation, two very successful countries have very similar approaches. From a strategic level, it's a government-wide approach with all sectors involved and the head of state. And from implementation, you decentralize but have an accountability structure so that the decentralization is reporting up. So it's fascinating that two countries that are successful are doing similar things. One of the important things you mentioned, Your Excellency, Madam Minister, is the accountability, which requires data and reporting systems. And Ambassador Goosebeard, John, maybe in that order, maybe you can talk a little bit about the importance of those accountability systems and the support you're providing to some countries to try to create those, because a lot of what they're trying to do rests on those accountability systems. Of course, they lead and set those systems, but maybe you could talk a little bit about some of the work you're doing to support their efforts.
I think that those systems become the eyes and ears of the policy decision makers at the clinic level, at the manager level within the clinic, as you move to the hospital, as you aggregate information at kind of district to province to national level. Each one of those loops need to be resourced, and there needs to be someone who is monitoring it, who is anxious and eager for that information to be complete. Because the data that comes in is, if it never gets back to that provider in the clinic who's seeing patients every day, but who you as the data retriever are dependent on to give you the data, you quickly fall apart. And then you start making decisions on partial data. And that can often result in inappropriate allocation decisions. So John has spent a tremendous amount of time trying to think about understanding what an analysis of expenditures gives us to increase our understanding of not only what things cost, which are critical, but what are the elements in the continuum of services that we have all, by countries leading, defined are the services we want to deliver and make available. How our expenditures reflect or don't reflect the support to that continuum of service. And making those connections requires an intelligence in the system that if it is not present at the highest level to keep the expectation at the ministerial level, it all kind of falls out. But I'd let John kind of put some meat on it.
Yeah, so I think one of the strengths of the global HIV response was to get accountability around program outputs in early and strong. It wasn't perfect to start, it wasn't fully integrated to start, but over time those systems got better and better. The other thing that happened early on is there was a lot of attention paid to treatment and treatment cost, what the drivers were, intensive studies around those. But we're actually seeing that there's a need for, especially in a rapidly changing, very dynamic HIV response, which varies now by country, and often locally, as we talked about the different epidemics, to develop systems around tracking expenditures linked to those results, linked to those program outputs, that would allow us to understand how monies are spent to produce the outputs they create by geographic region, whether it be province or state or department, by program area, by cost component for personnel costs, by implementer itself. And to be able to then use that information to help inform where there are outliers. Are there good reasons for the outliers? Are there problematic reasons for the outliers? Are there potential new models of implementation that look very promising? And then also for the planning purposes, to be able to use those data to actually show how the resources are allocated in a meaningful way, knowing that we have multiple partners coming together, multiple donors, and especially with the coordination with the national governments, with the Global Fund, to sort of better align the resources. So PEPFAR has been piloting this for 2 years now, moving toward routine implementation of the system. We're calling it expenditure analysis, but then also in dialogue with the national partners, with Global Fund, with World Bank, about how to look toward a broader system that actually is fully integrated.
Thanks. Sean?
Yeah, if I may add, from our experience, on the broader context, actually, AIDS response is getting into political arena. So sometimes Ukraine and Russia are competing who is more effective in planning. Sometimes we feel pressure from Russia to impose some limitations on AIDS response. In Ukraine and Central Asia, particularly on work with injecting drug users. So it's very important not to see this as a threat, but also as an opportunities, and to look on the allies. In our case, due to international support, we managed to achieve a lot of positive changes by introducing evidence-based practices, by pushing government for allocating more resources, particularly for IRT treatment. Another thing, perhaps it's not a secret to anyone that procurement also seen as a potential area for corruption. Yeah? I recollect in times in Ukraine when government bought IRT drugs, paying prices up to 20 times higher than we did at the same country at the same time. It was a huge difference. So due to accountability and great pressure from civil society, current prices are about the same, so they got normalized. It's very important factor in a situation of limited resources. Another thing is policy changes. Just last week, Ukraine adopted a new law, special law regulating tax exemption on the Global Fund grant, which will come to the force from 1st of January next year, but still the law is adopted for now. It will bring several million US$ savings to AIDS response.
Okay.
That's good. But I want to say that politics is not always bad. They are good politics.
Yes.
And I'm very proud to serve the one I'm serving, because it's oriented to the good of the individual.
Yeah.
And that's the change. And corruption is not a fatality. It has to be in the principle of governance. If not, the communities are lost, and we always have to have who is going to benefit, who needs it. And this is good politics.
Great. Thank you very much, Minister. Unfortunately, we have run out of time, and there were just so many other questions that we had for you around funding accountability. But I would like to thank the panelists for taking the time to be part of the panel. Deputy President, Minister Andrei, Eric and John, thank you very much. I'm not sure that we answered all the questions. There was interesting examples, interesting experiences, and interesting phrases: accountability, consensus, working together, politicking. I hope that you've been able to take something out of the session, and hopefully we are able to learn from countries like Rwanda in terms of how we can apply effective responses to HIV. So for your time, thank you very much. Enjoy the rest of the conference.